I just wanted to include this slide discussing cancer of the gallbladder. Really, the slide says everything that you need to know. The symptoms are anorexia, weight loss, nausea, vomiting, general malaise, jaundice, and hepatosplenomegaly. Folks who have gallbladder cancer, first of all, it's a relatively rare cancer, but people who are diagnosed with gallbladder cancer have a generally poor prognosis. The possibilities are surgery, radiation, and chemotherapy. Let's discuss pancreatitis. In order to talk about pancreatitis, we should talk about the function. Pancreatitis is serious and possibly life-threatening inflammation of the pancreas. It's caused by excessive pancreatic enzymes that destroy ductal tissue in pancreatic cells, and that ends up in an autodigestion of the pancreas. Autodigestion and fibrosis. The extent of pancreatitis can range from mild with edema and inflammation to necrotizing hemorrhagic pancreatitis. The pancreas has two different functions: the endocrine function and the exocrine function. The endocrine function of the pancreas is what we are probably most used to, in that it's discussing insulin secretion, so metabolism. Whereas the exocrine function is enzyme secreting. The enzymes that are secreted by the pancreas include trypsin, lipase, and elastase. These enzymes break down starches, proteins, and fats, and they're normally not activated until they reach the small intestine. If they get activated early, it can cause pancreatitis. This could be because of obstruction or edema with other issues going around in the peritoneum. Figure 59-2, the process of autodigestion in acute pancreatitis in your 8th edition of IGGI on page 1219 is a good visual. Elastase, which is one of those enzymes that the pancreas secretes, causes blood vessels and ducts to dissolve, leading to bleeding. Kallikrein is another enzyme, and it releases vasoactive peptides and increases vessel permeability, which also increases bleeding. So we have another theme here. Causes of pancreatitis, the most common is biliary tract disease, and gallstones are the most common in that biliary tract disease that causes pancreatitis. Trauma after surgery is another one. Page 1220 in your 8th edition of IGGI has a full list of potential causes for pancreatitis, so please refer to that. Incidence and prevalence of pancreatitis. Pancreatic attacks are especially high during the holidays. That's generally because people tend to eat poorly and drink more alcohol. Women are more commonly affected after gallbladder issues, especially when they have biliary tract obstruction, whereas men are more, their pancreatitis is more associated with alcoholism. Women, though, also see pancreatitis within several months of childbirth. Prognosis of pancreatitis: death occurs most frequently in older patients, as well as post-surgical pancreatitis patients. If pancreatitis accompanies alcoholism, then there's a worse prognosis, whereas if it accompanies biliary tract disorders, we have a better prognosis. On page 1219, table 59-2, and the title of that table is Potential Complications of Acute Pancreatitis. Some of those are jaundice because of the slowing of bile through the bile duct, hyperglycemia because of the release of glucagon and the decrease in insulin due to damage of the pancreas, damage of the islet cells. If we have total destruction of the pancreas, we will see, obviously, type 1 diabetes because of the damage to the islet cells. Left lung pleural effusions and atelectasis and pneumonia are a complication of acute pancreatitis. Necrotizing hemorrhagic pancreatitis, which could cause multi-organ failure. Acute respiratory distress syndrome, coagulation defects, including DIC or disseminated intravascular coagulation, hypovolemia, and that could cause decreased renal perfusion, which could cause renal failure, and shock. When we're discussing acute pancreatitis with a patient, assessing them for potential pancreatitis, we need to discuss a lot of those sensitive things again. Do you use alcohol? How much? How long have you used alcohol? Is there a family history of pancreatitis or alcoholism? Abdominal surgeries. Have you had any abdominal surgeries or diagnostic procedures lately? There are some associated diseases with pancreatitis, like peptic ulcer disease, renal failure, and vascular disorders. We'll want to know about that. Hyperparathyroidism. Has the patient had any recent viral infections? And of course, we want to know all of their current medications and supplements. Clinical manifestations of acute pancreatitis: severe, constant abdominal pain. It's usually in the mid-epigastric or left upper abdominal region. It's usually a sudden onset. It might radiate to the back or the left flank or the left shoulder. Usually pain is worsened in the supine position, and the fetal position could provide relief. At this point, I'd like to stop and say that we should make sure that we are conducting a pain interview or a historical interview after a patient's pain is under control. We want to know about the pain, including when does the pain occur. Is it after drinking alcohol or after a high-fat meal? Do they have nausea and vomiting? Have they had any weight loss? Jaundice? With our physical assessment, we might see gray-blue discoloration of the abdomen, flanks, and periumbilical area, abdominal tenderness or rigidity and guarding, and that would be due to peritonitis. We could have a palpable pancreatic mass. For these folks, we're going to be doing frequent vitals because of the possibility of seeing an elevated temperature, tachycardia, and hypotension. Table 59-4 is titled Causes of Laboratory Abnormalities in Acute Pancreatitis. That's on page 1221 in your IGGI book. Discusses some of those labs, including amylase levels, and that's going to be the serum amylase usually increases within 12 to 24 hours and remains elevated for 2 to 3 days. So not very long, especially if a patient waits a little while to come in. Whereas lipase is also elevated in acute pancreatitis, but it's usually elevated for a little bit longer period of time. So that might be a little bit more indicative of acute pancreatitis if a patient has kind of been nursing this abdominal pain for a while. Amylase levels might stay elevated longer if we have a pancreatic abscess or pseudocyst, and also amylase levels are going to be elevated in the urine. Lipase levels will also be elevated in urine. Serum bilirubin, ALT, and alkaline phosphatase levels will be elevated. White blood cells and ESR, as well as glucose could be elevated as well. Folks with acute pancreatitis, abdominal ultrasound is less reliable in this abdominal issue because pancreas is kind of hidden. So for acute pancreatitis, CT with contrast is generally going to be more reliable. Priority of care for acute pancreatitis is pain control. After that, we'll see nutrition because patients are not able to ingest food because of nausea, vomiting, and anorexia. And then when they do ingest food, they're not able to absorb nutrients as well because of the digestive enzymes not being secreted appropriately by the pancreas. Non-surgical management of acute pancreatitis is going to be IV fluids, pain control. We're going to have them fasting, so they'll be NPO. That's going to be to rest the pancreas and reduce pancreatic enzyme release. We want them to rest as well. Some folks might have an NG, and that's going to help prevent vomiting and biliary obstruction, which in turn will help prevent paralytic ileus. Many patients will have opioids prescribed as well as H2 blockers like ranitidine or a proton pump inhibitor like omeprazole. We might see people on antibiotics. It's not uncommon at all. Surgery is generally not needed for acute pancreatitis, but if pancreatitis is due to gallstones, we might have to see a gallbladder removed, or if the stones can be removed by ERCP, we'd do that. But then otherwise, if they can't be, a gallbladder might have to be removed surgically. Education, of course, is going to be improving diet and stopping alcohol altogether. Here is an image of acute pancreatitis. This is a CT, and you can see the arrow pointing to stranding, which is a common finding in pancreatitis. You can also see multiple gallstones in the gallbladder, which is the cause of this person's pancreatitis. We have here a diagram, a flow sheet of autodigestion in acute pancreatitis, which is very interesting, and it kind of gives you the flow of how you can expect things to occur in pancreatitis and essentially why it causes problems, especially pain. Here are those complications of acute pancreatitis. We've already discussed them and saw those in the flow sheets. Chronic pancreatitis is a progressive, destructive disease of the pancreas characterized by remissions and exacerbations. We've seen that throughout our course in other inflammatory diseases as well, like ulcerative colitis and Crohn's disease. Those periods of relative wellness with exacerbations in between. Chronic pancreatitis is caused by inflammation and fibrosis of the tissue, which is going to lead to pancreatic insufficiency and decreased pancreatic function. Chronic calcifying pancreatitis is the most common type, and alcoholism is the primary risk factor. What happens in this type of pancreatitis is proteins plug up the ducts, and that causes inflammation and fibrosis. Chronic obstructive pancreatitis develops due to inflammation, spasm, and obstruction of the sphincter of Oddi, and usually this is due to gallstones. So the pancreatitis, this pancreatitis is due to the fact that the enzymes can't get into the small intestine because of obstruction of the sphincter of Oddi. Autoimmune pancreatitis is chronic inflammation where immunoglobulins invade the pancreas. Unlike chronic calcifying pancreatitis and chronic obstructive pancreatitis, autoimmune pancreatitis does not seem to be a risk factor for pancreatic cancer. Idiopathic and hereditary pancreatitis is another type as well. When we have chronic pancreatitis, we have fat malabsorption, which is caused by the decrease in pancreatic enzymes. So fats can't be broken down or absorbed, and it leads to muscle wasting and weight loss. We also are going to see starvation edema with protein malabsorption. And so what that is when we have, kind of like what we talked about with ascites, where we have a decreased amount of protein in the serum, so we have third spacing. where the hands and the feet and the legs are going to swell or have edema because of decreased levels of circulating albumin. People with chronic pancreatitis are going to need enzyme replacement. Pancreatic enzyme replacement therapy prevents malnutrition and malabsorption and weight loss. Pancrealipase is probably the most common one, and I'm sure many of you have given this as drug therapy and enzyme replacement for chronic pancreatitis. Usually it's given in a capsule or tablet, and it contains amylase and lipase in varying doses, and it needs to be taken with all meals or snacks. Everything you eat, you need to have these enzymes. It's kind of a crapshoot, because the dose is going to change. We essentially start with a dose and hope that it's correct. The patient needs to monitor their stools, and if the dose is effective, the stools are going to become less frequent and less fatty. So then we know that they're at an appropriate dosage of the pancrealipase. Chart 59-3. Patient and family education, preparing for self-management, enzyme replacement for the patient with chronic pancreatitis is a good chart for that information. As far as nutrition therapy, we're going to be focusing on high calorie, high protein, low fat diet and avoiding alcohol. Here is a CT of chronic pancreatitis. And this is showing pancreatic calcifications. Pancreatic carcinoma. Pancreatic cancer is the leading cause of cancer deaths in the U.S. every year. Pretty much it has a lot to do with the fact that, like we talked about earlier, the pancreas is relatively hidden. It sits so snugly in our abdominal cavity that behind other organs that it's really difficult to diagnose early. Usually when we do diagnose it, it's by CT with contrast. Sometimes, depending on what the tumor is, you can see it with ultrasound, but CT with contrast is really the best way. Treatment has limited results, and the 5-year survival rate of pancreatic cancer is low. Primary adenocarcinoma or metastasis from cancers of the lung, breast, thyroid, and kidney are most common. So if it's a primary pancreatic carcinoma, that's going to be an adenocarcinoma, but it could be a metastasis from the lung, breast, thyroid, kidney, or skin. Primary tumors grow pretty rapidly and are going to spread to the surrounding organs, so those are those adenocarcinomas. Venous thromboembolism are a common complication of pancreatic cancers. The cause of pancreatic cancers are unknown, but some high-risk populations are patients who have a history of smoking, patients who are in their 50s to 70s, and there's a list of other risk factors on page 1227 in your 8th edition of IGGI. The presentation of pancreatic carcinoma is usually pretty vague, and the first sign might be jaundice, which usually suggests pretty advanced late disease. Chart 59-5 is titled Key Features Pancreatic Cancer, and that's page 1227 in your 8th edition of IGGI. And here we see a photo of carcinoma of the pancreas. It shows kind of how ill-defined that pancreatic mass is, and we can only assume that this is probably an autopsy. It's possible that it's a biopsy and the pancreas was removed, but as we've learned, pancreatic cancer is life-threatening.